Hello, everyone. Thank you for joining us for our second part of our webinar, Everything You Wanted to Know About vEDS. I'm going to briefly introduce our presenters for today. So we have Professor Tristan Mirault, who's a professor of vascular medicine at Hôpital Européen Georges Pompidou in France. We also have Dr. Anna Stenborg, who's a physician specialized in vascular Ehlers-Danlos syndrome in Uppsala University Hospital, Sweden. And to moderate this session, this Q&A webinar today, we have Eva Collado, who is the European Patient Advocacy Group co-chair for the Medium-Sized Arteries Working Group, and also the Vice President of the Spanish Patient Organization for Ehlers-Danlos Syndrome and Hypermobility. We have received questions from patients all across Europe, speaking in their own languages, and we'd like to show you these questions before we delve into other questions that we've received from patients, and our experts will go forward to answer these questions. Thank you.
Hola, me llamo Sandra, tengo 37 años y soy de Madrid, España. Mi pregunta es si sería perjudicial la lactancia en mujeres con sed vascular si todo se ha desarrollado bien en el embarazo, el parto y el posparto. Muchas gracias.
Bonjour, je m'appelle Manon Guerrier, je suis française et ma question est la suivante. Les bêta-bloquants, la ruboxytorine ou l'enzastorine, 500 mg par jour, donnent un effet bénéfique en termes de survie chez la souris. Est-ce qu'il y a une étude de phase 3 initiée chez l'homme? Merci.
Ciao, sono Alessandra dall'Italia. La mia domanda per voi è questa. Alcune cliniche offrono trattamenti con cellule staminali ai pazienti di esse vascolari. Ma esistono prove scientifiche su questi trattamenti come risultati degli studi clinici? Vi ringrazio, ciao a tutti.
Hoi, ik ben Iris en ik kom uit Nederland. Mijn vraag is, welke preventieve middelen kunnen helpen om geen herhaling te hebben van darm- en maagrupturen of perforaties? Is er meer evidentie dat na een darmperforatie de darmen opnieuw getroffen kunnen worden? Dankjewel.
Hi, I'm Jackie Fish. My son, who is 24, has vascular EDS with associated complications of arterial dissections, pneumothorax and bowel perforation. My question regards surgery. VEDS surgery is risky due to the ruptures and it might threaten life. Are low-risk invasive surgery procedures possible for VEDS patients? How can a plan of action before surgery be achieved to minimize the risks? Thank you.
Hola, mi nombre es Victoria, soy una persona afectada por el Ehlers-Danlos vascular y me gustaría saber, en una persona que ha tenido bastantes roturas arteriales, ¿el embarazo está totalmente contraindicado? Muchas gracias.
Bonjour à tous, je m'appelle Vincent, patient 7V, papa de jeunes enfants 7V, résident en France. Ma question est la suivante. À quel âge est-il recommandé de prendre le celiprolol? Merci.
Ciao a tutti, sono Francesco. La mia domanda è, secondo voi terapie digitali per il dolore lombare come Relivrex approvata da Food and Drug Administration negli Stati Uniti possono aiutare anche i pazienti con la vEDS? Grazie.
Hola, mi nombre es Alan de España, de Madrid, y mi pregunta es, ¿qué tipo de ejercicio podemos realizar que no tenga impacto y que no haya que hacer fuerza a la vez que fortalecemos la musculatura? Muchas gracias.
I'll be handing over to Eva Collado, who will be moderating the session and taking all the questions and have our experts answer them. Thank you, Eva.
Thank you, Treasure. So, good evening to everyone. Guten Abend, bonsoir, guten Abend, buonasera, buenas tardes, good kväll to everyone that is watching us today. So we will start again with the questions that we have received from patients with vascular EDS. And as last time, we are gathering them in different categories. So we are starting with genetics. And the first question is vascular EDS inherited from the mother's side or from the father's side? Tristan, would you like to answer the question?
Yeah. Thank you very much. I'm very happy to answer to patients' questions in this webinar. So regarding the mother side or the father side, actually, if the father has the vEDS, he can pass it to his child. If the mother has vEDS, she can pass it to her child. there is no difference actually if VDS come from the mother or from the father. And quite often, VDS patients do not have parents bearing the mutation from the father or from the mother. In that case, it is a new mutation which has occurred in the patient directly.
Thank you very much. So the next question. I am a vascular EDS patient verified by Hôpital Pompidou. But can I have any other type of Ehlers-Danlos syndrome, specifically hypermobile Ehlers-Danlos syndrome? Tristan?
Yeah. It's a very frequent question coming from patients. Can we share different types of EDS, Ehlers-Danlos syndrome? But actually, a genetically confirmed VDS imply the mutation in the COL3A1 gene. It is a gene coding for the collagen type 3. Therefore, it cannot be another EDS type. But we should keep in mind that symptoms can be shared between the different types of EDS, like skin or joint feature, for example.
Thank you, Tristan. It is indeed a very, very popular question amongst the patient community. So the next question, is COL3A1 the only gene that causes vascular EDS?
Well, yes, it's a 99% of the mutation responsible for the vascular Ehlers-Danlos syndrome affects the COL3A1 gene. There is rare mutations in another collagen gene, which is a COL1A1 gene, but it's very rare and it has the same feature as vascular EDS with vascular events, gut or bowel events, and uterine rupture can occur. So most of them are in the collagen type 3 gene, and very rare mutation can be found in another gene, which is a COL1A1 gene, still a collagen mutation.
Thank you. This was also a very popular question among the patient community. And the last question regarding genetics is quite a specific one. And the question goes, I have an arteriovenous malformation. The error in my DNA is MAP2K1. Has this error also been seen in Ehlers-Danlos syndrome?
Well, no, actually it's completely different. So the question was targeting Ehlers-Danlos syndrome, which should bear an S because there are different types of Ehlers-Danlos syndrome. And some of them have a gene recognized to be responsible for the disease, but the MAP2K1, which is a kinase, MA2P kinase, is not one of the gene responsible for any of the types of the Ehlers-Danlos syndrome. And it's not responsible at all for the vascular EDS. It's a completely different genetic disease. We can have arteriovenous fistula, which is a communication between veins and arteries in vascular EDS, but there is no relationship with the MAP2K1 gene.
Thank you very much. So we are moving to the next category, which is dealing with vascular EDS. And the first question, can vascular EDS patients receive injected adrenaline for anaphylactic shock? Does it imply any risk? And Anna, would you like to answer the question?
Yes, and thank you very much for this opportunity to join the webinar. The anaphylactic shock is a life-threatening situation, and you definitely should not hesitate to take these two kinds of medications, which are absolutely essential. And we don't worry about any risk in this situation with these drugs.
Thank you. The next question is somehow related to this one. Can vascular EDS patients receive a defibrillator shock or adrenaline injection for anaphylactic shock, the direct-to-heart ones, which carry more dose than the EpiPen for anaphylactic shock?
Defibrillator shock, that is only used really in cardiac arrest. And so it's definitely a life-threatening situation, or you would not hesitate to receive that treatment. It's completely necessary, and we would not worry about that treatment. Adrenaline injection into the heart is definitely not, would be risky, but it's not a part of the protocol for cardiac arrest. So, but other kinds of injection of high doses of adrenaline, when they are needed in cardiac arrest, then it's definitely needed, and you should receive it.
Thank you, Anna. That was very clarifying. Next question. Can patients receive ultrasound shock therapy?
We really, I at least do not know about this treatment, and I would not like to speculate really.
Thank you. So the next question, would the use of biological adhesives be a valid alternative to stitches for vascular EDS patients? Was this tested for vascular EDS?
These biological adhesives definitely can be used in vascular EDS, and it's often combined with stitches. To use only the biological adhesives, it seems not optimal. You really need more adhesion in these wounds, and normally stitches are kept for a longer time than in other patients. So they can be used, but maybe not the only method to treating a wound that needs stitching.
Thank you, Anna. We also have received the next question about fatigue. So my 16-year-old son has ectasia in his carotids and ascending aortic arc. He has POTS symptoms and chronic fatigue. Is there a safe way to non-medically treat the fatigue?
The fatigue, of course, may be caused by the POTS syndrome. You write about POTS symptoms, but if it's a question of POTS, then there are several possible non-medical treatments that should be tried before medication. And the main thing would be to recommend the patient to avoid bed rest as much as possible during the daytime, reduce it as much as possible, and also to exercise is very, very essential in this condition, and especially to build musculature in the legs, really, and also to increase intake of water and salt can be an important part of it. And there are also other non-medical treatments, and quite a few medical treatments as well in this quite painful. It's not a life-threatening condition, but certainly can be very, very troublesome for the patient and the parents in this case as well.
Indeed, this is a hot topic, also POTS and dysautonomia in vascular EDS patients and general EDS patients as well. So thank you. And it's impairing the quality of life also. So it's very helpful that you are giving this kind of advice. And the next question is about ectasia again. Can ectasia in both carotid arteries cause paler POTS symptoms or fatigue?
There might be that it can be a factor that contributes, but it would not be a major factor to interfere with this blood circulation, at least not in a younger person.
Thank you very much, Anna. So we're moving on to the next category, which is medication and research. And the first question we have received regarding this topic is as follows. Is there any drugs for vascular EDS treatment which is used outside of the European countries and which should be approved by the EMA too? Could patient associations support this? Tristan, would you like to answer the question?
Yeah, thank you. Actually, there is no EMA, European Medical Agency, or FDA, Food and Drug Administration in the US, approved medication in vascular Ehlers-Danlos syndrome up to now. But the European Union is fostering the registration of off-label use of medication in rare diseases. And there is a European regulation for the designation of medicinal products as orphan medicinal products and to provide incentives for the research, development, and placing on the market of designated orphan medicinal products in rare disease. In line with VASCERN, the patients' associations can help at registering tested drugs in vEDS to obtain this EMA label. But even with the EMA label, it does not make sure that the drug will be available in every EU country. So this is how patients' association could support the effort to register the different medicines already used in vEDS. And then the step after will be to fight to obtain the drug in every country.
Thank you very much. The next question is again about research. PKC beta blockers, roxastatin and zastatin, gave a large positive effect regarding survival in a study in mice. Has a phase 3 study been initiated yet?
Yeah, actually the PREVENT trial was aiming at testing enzastatin versus placebo in vascular Ehlers-Danlos syndrome patients, but it has been suspended by the sponsor with indefinite hold by the company I2 Biopharma. We don't have any trial testing ruboxystorin or other drug up to now in this PKC beta inhibitor.
Thank you very much. And again, we go with the research. How do you feel about participating in PREVENT's new study with the drug enzastatin?
Well, as I already mentioned, the trial did not start yet, so it has been suspended by the sponsor. But it is important to know that only celiprolol has been tested in a trial in vEDS and demonstrated benefits in reducing arterial events. However, every new drug should be tested before prescription in patients, and we cannot foresee the true effect of a medication before analyzing the results of a randomized trial. A trial with irbesartan, which is a non-angiotensin receptor blocker, ended, and we are now waiting for the results within this trial. Acer Therapeutics is conducting a randomized controlled trial in the US testing celiprolol versus placebo. This is a DISCOVER trial, and it is recruiting patients in California since November 2022.
Thank you very much. And then yet another question on research that shows that the patient community is quite eager to know what is going on. Some clinics offer stem cell treatments to patients with vascular EDS. Is there any scientific evidence on these treatments? And are the results of clinical studies available? If so, thank you.
Well, it's a very important question. The answer is quite clear because there is no data of stem cells in vascular Ehlers-Danlos syndromes. Preclinical model, which is mouse model, or even less in patients. What has been reported is some data regarding the senescence of the skin and of animals in which there is reduction in the production of collagen. And so stem cell therapy can help at delay the senescence of organs like skin, for example, in animals. But again, it doesn't prove anything in a genetic disease like vascular Ehlers-Danlos syndrome. Just because it affects the collagen type 3, it's completely different. And so there is absolutely no data of stem cells in this genetic disease.
Thank you very much. We have also received a question regarding research in the chat. So you have already replied to the question, Tristan, but would you like to take it out loud so for those that cannot read the chat? So the question goes, do you have some result from the irbesartan trial?
Well, this trial has been conducted in France, and it randomized patients with already getting celiprolol to receive a placebo or irbesartan, which is angiotensin II receptor blocker. And it's a very common molecule medicine used in hypertension to treat high blood pressure. So the trial is completed, meaning that every patient has received either the placebo or the drug to be tested, and every patient had done the follow-up. So the database is under consolidation and completion, and the analysis will follow soon with the result of this trial.
Thank you very much, Tristan. So we're moving on to another category, which is very popular, pregnancy. So the first question is, I would like to know if there are any studies on whether natural childbirth or cesarean section is better for women with vascular EDS who have not had yet severe episodes of the disease. Anna, would you like to answer the question?
Yes, and unfortunately, the answer is that there are no randomized trial concerning this question. But there is for sure a consensus among the VEDS experts to recommend cesarean section for many reasons. You can have better blood pressure control, and so even though it has not been specifically studied in a randomized trial, there is a consensus for cesarean section.
Thank you very much, Anna. The next question, would breastfeeding be harmful in women with vascular EDS if everything went well during pregnancy, delivery, and postpartum?
Well, here we would focus on the recommendation that also after delivery, the mother continues to take celiprolol or another beta blocker, not only for the first period after delivery, but long term. And since that drug will pass on to the breast milk, we would not recommend breastfeeding. We recommend against breastfeeding mainly for that reason.
Thank you very much. What are the rates of death, uterine perforation, arterial dissection, and other events in pregnancy in a woman with vascular EDS? What are the statistics on problems arising in a pregnancy with vEDS?
There is one large study from 2014, and there was more than 500 births from around 250 women. And the statistics, the result was unfortunately 5% death and only 3% uterine rupture. So that was more rare. And arterial happenings such as rupture or dissection was 9%. But in this study, most of the women had not had the vascular EDS diagnosis before the delivery. And it's difficult to know what conclusions you can draw from this study. But you need to consider every patient who wants to be pregnant individually. It requires to consider all factors, and it requires a multidisciplinary team to help with in any decision of pregnancy concerning pregnancy.
Thank you very much, Anna. So now we're moving on to the next category, lifestyle. What leisure activities can or can't be done now? I mean, after the diagnosis. Jumping trampoline, Cooper test at school, gymnastics, going off a diving board, and so on. Anna, would you like to answer the question?
Yes, it is a difficult question. Really, you do not want to restrict physical activity in young children and school children. It's problematic for so many reasons. So the main idea, especially for the youngest children, is to not restrict. When it concerns activities in school, it's a good idea to connect with the teachers and give information so that they can consider the diagnosis and avoid the most risky activities. And of these activities that mentioned in the question, Cooper test is not so. Cooper test, trampoline, diving board seem not the best activities for children with vascular EDS, but it's really difficult, and you need to have all sorts of factors to consider. You don't want to interfere with the children's life too much, really.
Thank you, Anna. And another question, are there any risks in going up to the mountains above 1,500 meters, above the sea, or diving?
Well, climbing mountains, unless it's a very risky kind of mountain climbing, this ascent should not be of concern. Concerning diving, you would want to avoid really deep dives that exposes the body for very increased forces. So just snorkeling is definitely good and encouraged and a good thing to do, but the very deep diving should be avoided.
Thank you very much. We have also received a question regarding lifestyle in the chat, which has been already replied by Tristan. But since it's a very, very popular and usual question, I think it's worth it reading it out loud. So the question is, how do you build muscle with vascular EDS? So Tristan, since you have replied the question, would you like to reply it again?
Yeah, so I replied directly to the question, which is, how do we build muscle in VDS? You build muscle normally because collagen type 3 is not a protein very essential for muscles. But I guess the question was more addressing bodybuilding and to make heavy muscles like I don't have. And so actually, heavy weightlifting is definitely not indicated in vascular EDS because it increases heavily the blood pressure during exercise, and also it stretches the arteries and exposes the artery to stress. And so the risk is to increase the vascular events by doing heavy weightlifting and bodybuilding. But intermediate intensity exercise, long duration exercise is definitely good for health and is not prohibited in vascular EDS. So exercise is not prohibited, but heavy weightlifting and very high speed, high dynamic sports should be avoided.
Thank you very much. We do have a very active patient community because we keep on receiving these questions about sports, activities, diving, going on a plane, and so on. So it's nice. It's nice also for them to get some directions. So we are moving on to the next category, risk and intervention. And this has been by far the most popular category in this session today. So we will start. Aneurysma may stabilize. What affects that? Would you like to take this question, Tristan?
Yeah, definitely. We do not know actually why some aneurysms grow slowly and stay quite stable and why others grow rapidly. There's no clear factors affecting the speed. Maybe for another disease, which is atherosclerosis, the control of the blood pressure, if it's not correct, it's more associated with an increase of the aneurysm. But here in vascular EDS, we don't have the clue to understand why some aneurysm grow slowly and others grow rapidly. And to be precise, one arterial aneurysm always grows. It's due to physics law, but the expansion rate is not known, and there is no clear factor to anticipate the speed of the progression of the diameter of an aneurysm. On the other side, we also talk about false aneurysm, which is not exactly the same. It's a local blood effusion around the artery due to a small hole or small rupture, and it can mimic an aneurysm. But false aneurysm can heal after compression, for example, of the femoral artery. Generally, false aneurysm of visceral arteries cannot heal by themselves. They should require intervention to provide a more complex rupture of the artery.
Thank you. Thank you very much, Tristan. The next question, do you see vulnerability to events in particular age groups? And if yes, do hormones play a part? And this patient is commenting that I notice a lot of posts on Facebook about young men in their 20s with severe complications from the vascular EDS and wondered if higher testosterone levels might be a contributing factor. Do you see any evidence that these incidents occur at a certain age, in, for instance, puberty, young men in their 20s, and so on?
Yes, so there is some indication of this. The risk of complications increase at the end of puberty and is higher in boys than in girls. And testosterone may be a clue and probably have a role in worsening effects on arterial fragility. And it has been shown in mouse models of vascular EDS. The question coming after is, can we avoid this increase of testosterone in young boys? But it's quite complicated because it can affect the sexual appearance, and so there is research on preclinical model on this, and to better understand the role of testosterone on the arterial fragility.
Thank you. Thank you very much. Very interesting. What measures other than blood pressure meds can be taken to minimize the risk of spontaneous dissections which occur with no trauma and when at rest? Anna, would you like to take this answer?
Yes, I have one suggestion concerning this, and that is to consider extra consider keeping your hands clean, to have increased attention to that, to reduce the risk of getting a gastrointestinal infection, which leads to vomiting, and very heavy vomiting has been associated with dissections of the renal arteries, for example. So it's a small thing you can consider, washing your hands often.
Thank you. Is it possible to have had dissections while undiagnosed and scans come back clear 5 or 6 years after, once diagnosed?
Yes, small dissections, they can heal completely, and sometimes when you do a new scan, they are not visible.
Thank you, Anna. How likely is that a person with vascular EDS that was asymptomatic their whole life develops symptoms later in their life, for example, after her or his 50s?
It is not very frequent, but it happens. So I have met at least one man who was over 70 years old when he developed symptoms and was diagnosed. Not frequent, but it happens.
Thank you, Anna. So is someone diagnosed at 2 years old likely to have a more severe case of vascular EDS?
It really depends. If this diagnosis is because of symptoms from the child itself, then it is more serious prognosis. But if this 2-year-old had a diagnosis from screening because of a family member had vascular EDS, then it's not a worse prognosis.
Thank you very much. We have another question. When is a cure and or treatment for vascular EDS going to be real? So Tristan, would you like to take this one?
Yes, can you just, because I was answering a question in the chat, can you ask again the question? Sorry.
Of course. When is a cure and or treatment for vascular EDS going to be real?
I was not sure to have heard the question clearly, but yes, yeah, I can understand that this is a goal for every patient to have a news that there is a treatment that will cure vEDS. But we talked about that in the previous webinar about genetic therapy, and it seems complicated for the future, for the close future, to think about therapy based on gene editing, for example, of the collagen type 3 mutation, for many reasons. So for the cure of vEDS, we don't think it will be in the close future. But for new therapies and new treatments, there is researches done on preclinical model, mouse models. And as already mentioned previously, the protein kinase C inhibitors, the hormone balancing therapies, the blood hypertension therapy, antihypertensive drugs has been tested, and we are waiting for results. So it may come very soon in practice that we will, for example, add a new drug or an already known drug, but a new treatment in VEDS for the patients. So we still have hope that we can reduce the number of arterial events, the number of gut or bowel events in patients affected by vascular LTS.
Thank you, Tristan. Hope is the key word. So let's keep on hoping and also hope for this cure to arrive as soon as possible. So thank you very much. The next question is about the domino effect. So the question is, we have experienced that, yes, we have seen with my son that one problem and the subsequent treatment has then led to further issues. For example, routine surgery was followed by artery dissections, and then a more recent VAD caused more problems, and then he suffered a colon perforation, and so on and so on. Then this led to a pleural effusion and pneumothorax. So is there any literature or suggestions on how to advise clinicians on the best ways to treat vascular EDS patients to mitigate this domino effect risk?
Clearly, we also see the domino effect in the patients we follow and we provide care to. That's why for every acute event, recommend to strictly control the blood pressure with antihypertensive drugs, sometimes intravenously, and also to control the pain. Because the pain actually and the stress, the anxiety related to the hospitalization related to the acute event is increasing the level of blood pressure. So we very recommend to monitor the blood pressure and to lower to the very low pressure the arterial blood pressure. In addition to that, we also recommend to manage the anxiety, because if you can prescribe anxiolytics, the patient will be with less stress, and the level of blood pressure will also decrease. And in the same way, it is important to take care of constipation, because sometimes due to the pain, you use, for example, opioids or morphine analgesics, and it increases the risk of constipation and then the risk of bowel rupture. So all these medications around the anxiety, the stress, the pain due to the event should be taken into consideration, and monitoring the blood pressure is really, really important. And we reach a very low level of blood pressure. The systolic arterial blood pressure should not be above 120 millimeters of mercury and be contained around 100 millimeters of mercury in this very acute phase around the event. And then after days and weeks after the event, we can relieve the pressure with medication and go back to the previous prescription.
Thank you very much, Tristan. The next question is more a comment than a question. My son's dissections have all been with no trauma, with exercise and high blood pressure. Would you like to comment on that?
Well, yeah, very briefly, but we agree that arterial dissection in vascular EDS is usually the case without trauma. So it's particular to this genetic disease that there is no factor responsible for the dissection, or sometimes because of very dynamic exercise, as already mentioned, heavy weightlifting, which increase rapidly the blood pressure. The artery can have a tears and there's a blood effusion. But in the vast majority of the case, there is no reason why the dissection occurs. So we call them spontaneous dissections.
Thank you. Quite clarifying. Thank you, Tristan. Next question. Me, my sister, my father all have vascular EDS. My father was diagnosed very recently. He is 55 and had a scheduled surgery for leg meniscus. The surgery was supposed to be in a private hospital. However, after his diagnosis, they refused to go forward with it as they are not aware of vascular EDS. What route should my father take as he has constant leg pain?
Well, I guess it's a frequent question and situation because there is many medical situations that vascular EDS patient can face. And so we always recommend that to undertake surgery, this should be done in a reference center, meaning in a medical center where there is physicians aware of the disease of vascular EDS, doctors, surgeons, but also anesthesiologists, because they know what to do and what to not do in VDS patients. And there is often a multidisciplinary team that will take care of the patient to be sure that the surgeon can perform the surgery safely, that the anesthesiologist is aware about any complication, for example, arterial ruptures that can occur, and so he can manage rapidly the patient, and that the physician is aware that VDS patient in the hospital and can take, as mentioned, the anxiety, the pain, the constipation, or the environment around the surgical intervention.
Thank you, Tristan. It is indeed a question that we often receive in the patient organizations. And as you mentioned, awareness and knowledge by the medical team is crucial. It's crucial for the patient. Our next question. We have a very interesting one. Is there any risk for a vascular EDS patient to be sexually active?
Yes, very interesting question, and I thank the patient for asking that, because I think many of the attendees have this question in mind regarding the exercise recommendation that we can give. We cannot give a categorical answer, of course. We have no data to refrain sexual activity in VDS. Actually, it's not a very common question from our patients in consultation, but I'm sure, as mentioned, it is a question that every patient and family affected by one patient have in mind. We have fathers and we have mothers, meaning that sexual activity has been safe in many occasions. So I will be reassuring about that. But as mentioned, we cannot give a categorical answer on being very active in the sexuality. But still, there is fathers and mothers, so I think it's fine.
Thank you, Tristan, and thanks to the brave patient that shared the question with us. And the last question for this category: how much the minor characteristics like typical face, acrogyria, alopecia influence the severity of arterial rupture in terms of longevity?
Well, it's a very good question, but we actually do not have robust data to relate these minor signs, which is signs of the Vascular Ehlers-Danlos syndrome, with the severity of the arterial or the gut or the uterine rupture. So, and this is the same for longevity. So I cannot give advice to patients if they are acrogeria or typical phase that they will have more severe symptoms. As Anna said, we can have patients with a diagnosis at a very late age, and so these minors are not associated with the severity of the events.
Thank you very much, Tristan. And then we will take now the last category for today, which is pain. So the first question is about pain and hormones. Is low testosterone in women a factor for pain? And then we can take this question with the next one, which also has to do with hormones. Is low estrogen in postmenopause a factor in increased pain? So Anna, would you like to take both answers to the question?
Yes, it's a very, these are very interesting questions, and I'm sure the reason why we ask these questions is that in general, women are more suffering from chronic pain. Many more women suffer from chronic pain than men. So obviously, a lot of studies has been done on this question. And for estrogen, it seems there is not so much indication that the different levels of estrogen should be correlated to pain. But for testosterone, there is some indication that testosterone can reduce. A higher level of testosterone is associated with less pain. And of course, also women have testosterone, but not as much as men do. And some were considering menopause for women, and that there may be an increase in pain after menopause. And then it can be interesting to know that after menopause, testosterone in women is also reduced by circa 25%. So, of course, it's not maybe so helpful to know this about testosterone, especially since in vascular EDS, it may be not such a good factor when it comes to the vasculature. But when you're just want to understand things, testosterone seems more important factor considering different levels of pain in men and women.
Thank you, Anna. It's indeed quite interesting to understand how hormones and vascular EDS and pain work. The next one is a very futuristic question, or maybe it's a present already. Would you think that digital therapies for low back pain like Relief RX, approved by the Food and Drug Administration in the United States of America, would be beneficial to vascular EDS patients too?
Yes, it seems very promising. So it's definitely worth investigating or even trying. There is no reason why there would be a problem for VDS patients to try this therapy.
Thank you very much, Anna. So we have still some questions in the chat. So let's keep a very quick look. So yes, there's a very interesting one about, has there been any research into a link between vascular EDS and drops in saturation and sleep apnea? Tristan, you have replied this question in the chat. Would you like to quickly also reply now?
Yeah. So there is no precise data actually available on sleep apnea in vascular EDS, but it is known that there is an increased incidence of sleep apnea in classical type EDS. And so if a VDS, vascular Ehlers-Danlos syndrome patient has symptoms suggestive of sleep apnea, then a test to confirm the diagnosis should be performed, and if required, therapy should be introduced.
Thank you very much. Again, it's a very popular question. Is there a relationship between bleeding disorders like hemophilia and vascular EDS?
And I also answered to that question because, yeah, it's definitely, and there is a amount of researches that has been done in previous decades, but actually there's no link between hemostatic factor deficiency, for example, and VDS. The fact that bruising and sometimes hematoma can arrive in VDS patients is probably due to the fragility of the arteries and the small arteries in the skin, and also due to the extensibility of the skin that can stretch more easily than without collagen type 3 defect. So it is not coming from platelets or coming from hemostatic factors, that the fact there is more bruise and more hemorrhage in VDS.
Thank you, Tristan. We have a question about dissections, which has already been answered. So I'm just going to read it. Is it possible to have had dissections of medium arteries years ago before diagnosis and now have the scans completely clear? So yeah, Anna and Tristan, if you would like to comment on that.
Anna, answer.
Yes, it's definitely possible. Yes.
And as mentioned, this has already been explained by Anna during the webinar. Are there any studies on the effects of hormone therapy for transitioning in people with vascular EDS? Hormones again, it's also a very popular question. Tristan has replied, but would you like both of you to take the answer for the question?
So we mentioned that maybe there's a role of the hormones, and especially testosterone, on arterial fragility. So probably testosterone supplementation is probably not to be recommended in EDS. Regarding estrogen therapy, there's no reason to have concerns. There's no clear risk increase of venous thrombosis. So estrogen therapy is not contraindicated in case of EDS. And there was also another question from I don't know if it's the same attendee, but which was, would a hormone suppressant like testosterone suppressant be safe for a teenager who wants to transition to female? So I answered that maybe, but clearly we do not have scientific data that support that transitioning from male to female can prevent arterial rupture or bowel rupture or any events in VEDS. So it should not be recommended that for boys transitioning to female should be an option to avoid, for example, arterial event, because we don't have any data supporting this right now.
Thank you very much, Tristan. And the last question, vascular EDS and joint pain frequency. So Anna, you have already replied on pain. Would you like to comment a bit further on this topic?
Yes, I think physiotherapy is a very important part in this with this problem, to increase the musculature around joints, the large joints, perhaps mainly, to prevent, to stabilize the joint a bit. So it's not a quick fix, but really, really important.
Thank you very much. And we have received a very last question in the chat. So are there the lesions with less phenotypic aggressiveness? And do you have any evidence of that?
Yeah, we can definitely answer that. In general, we classify the variants, the genetic variants, the mutations, in dominant effect variants, which is the more frequent one, and the most frequent is affecting the glycine residue in the protein. And there is another type which is rarer, which is haploinsufficient vEDS. So it's a mutation causing the fact that you don't express one allele of the gene, so you produce 50% of the collagen type 3, but this 50% amount is normal. So you have a reduction in the amount of collagen type 3, but normal collagen type 3. Whereas in the more frequent form of vEDS, the dominant effect due to the mutation, you produce abnormal collagen type 3, and so there is more severe phenotype due to these mutations.
Thank you very much, Tristan. So I think we have replied to all questions we have received. So thank you very much for everyone that has been sending questions, participating today, attending, and to Tristan, to Anna, to Treasure, to Claire, to the whole MFA working group. And I would like to give the word to Treasure so that you can close the webinar today. Thanks, everyone.
Thank you, Eva. Thank you, Anna.
Well, thank you. Thank you so much. Thank you, Tristan. Thank you, Anna. Thank you, Eva. Thank you, everyone who attended, stayed from the beginning to the end. We're so grateful, and also sending your questions. I hope this session was quite insightful. Please look out on our social media handles pages for the recording and the replay of this webinar. And you can also share the replay with your family, friends, or anyone who wasn't able to join today, and watch and see the answers to the different questions. Have a good evening. Thank you. Bye.